All right, let's get started. Aloha, everyone. Welcome to the Queen's Free Speaking of Health lecture series. Tonight's lecture is called Understanding the Importance of Good Prostate Health. My name is Sean Ibarra from the Corporate Communications Department at the Queen's Health Systems. So our presenter this evening is Dr. Robert Carlisle. He is a urologist with the Queen's Medical Center. Dr. Carlisle has been in private practice in Hawaii since 1992. He also previously worked at the University of Utah in the preliminary surgery and urology residency. He attended the John A. Burns School of Medicine and previously served in the U.S. Army in Germany. He was born in Japan and raised in Idaho, Japan, and Hawaii, and he is a graduate of Castle High School. So let's please give a warm welcome to Dr. Robert Carlisle.
Well, I appreciate your taking the time to come out on this stormy night. It looks like it's not raining right now, but it may start up, so I appreciate your attending here and coming to work here. After my training, I did come back here. Some of you who are older may remember John Edwards. He was a urologist here, and he was also on the board of the Liquor Commission. He did a lot of other stuff too, but I ended up assuming his practice when I came to Hawaii, and it's been very rewarding for me, and I appreciate the opportunity that was given to me by Dr. Edwards. Tonight, I'd like to speak a little bit about prostate, and mainly about non-cancerous enlargement of the prostate. So I'd like to talk a little bit about the prostate, then go over an enlarged prostate, benign enlargement of the prostate, and what that is, and how it's diagnosed, and then talk about some treatment options. The prostate is part of the male reproductive system. In development, the prostate and the testicles and the ducts that come down into the prostate and the bladder, which becomes the urethra, they all meet at a junction, and that's how you end up with your sperm coming out through the urethra and your urine coming out through the same channel. It's a walnut-sized gland at the base of the bladder, and the urethra runs right through the middle of it. The purpose is when the sperm comes out from the testicles, then it allows the fluids that help support the sperm from the seminal vesicles, which sit up on just above the prostate, as well as the prostatic fluid itself. They form the ejaculate, which then exits through the urethra. If you think of, I do a lot of vasectomy, so if you think of the ejaculation, the fluid, as a glass of Kool-Aid, the fluid is coming from the seminal vesicles in the prostate, and the sperm is more like the Kool-Aid powder, so it doesn't occupy much volume at all. So I actually have to tell patients, you could look at a sample before and after, and you wouldn't know which is which unless you looked at it under the microscope. So the prostate does aid in reproduction. That's its main function. In puberty, it starts to enlarge, and it reaches adult size up to about age 25. And then after that, it keeps growing the rest of your life. And it may be a problem in some men. BPHB stands for benign or non-cancerous enlargement of the prostate, P relating to the prostate, and hyperplasia means that the cells are growing so that you get more cells than normal there. And when that gland enlarges, because the urethra is running right through the middle, that's when problems start to arise. You can see the normal prostate where the urine can flow through, and then on the opposite side is the enlarged prostate. So again, it puts pressure on the urethra, then the bladder has to squeeze harder and harder to get the urine out, and so that's when the symptoms start to appear. When the bladder thickens, you can think of it like a balloon. A thin balloon distends very easily, But a thick balloon is really stiff and hard and non-distensible, so you end up not holding as much urine before you feel full. Also, some people they come in for a check and they got a huge prostate, but they don't have any symptoms. Other people have a little bitty prostate, but it's squeezing down on the urethra, and they have significant symptoms. So the size does not correlate with the degree of obstruction or the severity of the symptoms. Who can get BPH? Well, it's the most common prostate problem for men over 50, and each year as many as 27 million men in the United States had symptoms. They call it LUTS, or lower urinary tract symptoms of prostate obstruction. We'll talk a little bit about the symptoms. And it affects 50% of men by the age of 60. That doesn't mean 50% of your 60-year-olds are going to be running around complaining of urinary difficulty, but their prostate is going to be enlarged. And by the time you reach 85 or 90% of the men are going to have an enlarged prostate. But again, that doesn't necessarily mean that you're going to have problems. The risk of BPH can be increased by a family history, obesity, and lack of exercise. BPH is not prostate cancer, and BPH does not cause prostate cancer. Although sometimes if you have cancer and it's obstructing the outlet of your bladder, your symptoms are going to be similar to that of one with benign enlargement of the prostate. Also, you could have cancer in your prostate and have BPH at the same time. PSA is a chemical that's made in the prostate and is a protein that's measured in the bloodstream, and it's used to screen for prostate cancer. But both a benign enlargement of the prostate and prostate cancer and infection or inflammation, they can all cause elevated PSA levels. So a PSA test is not going to sort everything out for you, but it's good as part of the sorting process. How do we diagnose an enlarged prostate? Well, we get an exam, history and physical exam. And let me jump here. Some of the symptoms are frequent urination during the day or night. How many times do you get up at night? If you get up maybe once, that's okay, or maybe even twice. But if you're getting up 5 or 6 times a night, that's too many times. And it could be a result of your bladder getting really thick and having to, because it has to squeeze against that increased resistance of the prostate, squeezing down on the urethra, and so it just doesn't distend and you feel full at maybe a third or half the volume that you used to feel full at. Also during the day, how often do you urinate during the day? Ideally, you might go 3 hours or so between urination, but some folks are going every hour or 2 hours. Of course, it depends if you just had coffee or something in the morning. Of course, you're going to urinate more often. But in the afternoon, do you still go every hour? Those are symptoms of an enlarged prostate. Do you have a sudden urge to urinate? One of the people have mild symptoms, but when they come in and if, as opposed to severe symptoms, when they come in and they say, I ask them, well, do you ever wet your pants? Do you ever get a sudden urge to urinate and you can't hold it? And you can't get to that bathroom and you're wetting your pants, or most commonly, folks with an enlarged prostate will get to the bathroom, they will have held it, then when they're pulling down their pants, it's coming out. But when you've gotten to that stage, you need some help. One can have painful urination, especially if there's an infection there that resulted from stagnant urine just sitting in your bladder, which can get infected, or if that stagnant urine forms some stones, or if your bladder's just full and not emptying and it's trying to get that urine out and squeezing all the time, you have spasms, and And that can give you painful urination when you just can't get it through that tight channel. I asked folks, how is your urinary stream? Most people who come into the office don't pee like they did when they were 18 years old. But, there's a regular stream and then there's a really weak stream. Does it dribble? Do you go twice? Do you go 3 times? Do you just kind of wait and then some more comes out? Or you sit down and 2 minutes later you go to the bathroom and some more comes out? Do you feel like your bladder never empties? And do you have trouble stopping or starting the urine flow? In other words, is it hard to get going, and then is it hard to stop? And of course, if you can't urinate, that gets your attention really quickly. However, there are some people who, very few, fortunately, who have a blocked, a very large obstruction of their urethra by the prostate, and number one, they must be pretty stoic, or they have poor sensory nerves down there, but their bladder must get slowly enlarged very slowly over time, and that they don't really notice it. And some folks come in and they got 2 liters in their bladder. It's just been stretched to an enormous degree. And fortunately, most people don't get to this stage, but when you can't urinate and your bladder's full, it catches your attention because it hurts a lot, and you go to the emergency room. The digital rectal exam of the prostate is the Okole exam, the prostate sits just in front of the rectum, and so it's really easy to feel. And that's an important part of the check for evaluating the prostate. One can feel the size of the prostate and also whether there's any nodules on it or hard lumps, which most of the cancers tend to arise in the periphery near the rectum, so we're feeling for hard lumps there, as well as some folks who have an infection. When you push on their prostate, they may hit the ceiling because they got an infection there and it's very tender. So those are the sort of things we're looking for. Just an aside, actually it's quite a few years ago, a friend of ours I was checking him in the office, and his prostate as a routine check, and he said, "Well, what's your son doing?" And I said, "Well, he's in dental school. I don't know how he can stand to look in somebody's mouth all day." And he kind of turned around and looked at me like, "You're kidding, right? Where is your finger?" I'm sorry, this is a very busy slide, but one way to objectify those symptoms is with the prostate symptom score index. And so there's a series of 7 questions, and they're asked, and you rate it. It's like taking a little test, and you rate your symptoms on a scale of, I never have this. For instance, the first one is over the past month, how long have you had the sensation of not emptying your bladder completely after you finished urinating? 0 is not at all, 3 is about half the time, and 5 is almost always. Over the past month, how often have you had a weak urinary stream, and so forth. So if you're tending toward the 4s and 5s, you have pretty severe symptoms. And once you answer these questions, then you add the numbers up. And if you're up to 0 to 7, then your symptoms are mild. If you're up to 8 to 19, they're considered moderate. And higher than 20, they're severe. And it's useful to use this because, again, it objectifies symptoms. And so if you're started on a medication, or if later on if you receive some sort of treatment, you can take the same index, and then we can see whether the score goes down or not. Also useful is a quality of life score, in which one is asked, if you were to spend the rest of your life with your urinary condition just the way it is now, how would you feel about that? Would you be delighted? Would you be mostly satisfied? Would you be unhappy? Or would you be terrible? So that's a good way of admitting to yourself and for the urologist to know, well, how much does it bother you? Because if it doesn't really bother you, then maybe you don't need any treatment. But if it bothers you a lot, then you do. Many men who suffer from BPH may experience a reduction in quality of life. Up to 95% of men with moderate symptoms are unhappy and don't want to spend the rest of their life with these symptoms. Half of men say BPH interferes with an aspect of their normal life. And 49% of men experience sexual problems associated with lower urinary tract symptoms. And of course, if your spouse is getting up all night and you're sleeping in the same bed, or you're always having to wait for them to go to the bathroom, then that affects your partner's quality of life. Other tests that will be checked will be a urine test, see if there's any blood there, see if there's any infection. Also, we mentioned a PSA. There are scans that can scan the bladder non-invasively. It's like a little bitty ultrasound, and after the person urinates, you want to know, are they running around with a half tank, or do they empty, or is it full? And so it's a simple thing to scan their bladder, and that's very useful to know if they're getting rid of all their urine. Sometimes we will perform a look into their bladder, into the urethra, with after numbing it up, with a flexible scope, and then we can see how big the prostate is, how much it's plugging it up, how much it's extending into the bladder, what the bladder looks like, are there any tumors or stones there, is the bladder really thickened. Before offering any sort of more invasive therapy, whether it's minimally invasive or more invasive, I like to take a look in with the scope in the office, so I'll know, well, if it's pretty open, then they're not going to benefit from the more invasive treatment. But most of the time I'm sort of amazed that they were able to urinate at all, because it's really plugged up. This is on one side that there's the normal bladder, ureter, and kidney, and then on the other side is a prostate or a upper tract system that's really gotten distended from the urine not coming out and backing up. The bladder's gotten very thick. The ureter, the kidney can't empty, so the ureter starts to dilate, the tube between the kidney and the bladder, and then the kidney itself can dilate. And even some folks who are obstructed chronically like this can end up having renal failure. As far as treatment goes, just because you go to a urologist's office doesn't mean that you're going to get surgery. If you go to the urologist's office and the first thing they sign you up for is surgery, then maybe you need to get a second opinion. But there's behavioral modification. Some folks are drinking a whole lot of water, and sometimes, or a lot of coffee, and sometimes changing your diet and your fluid intake may help. And so the first, we'll talk a little bit about this, is watchful waiting. You don't have to be on medication. You don't have to get any kind of surgical procedure if your symptoms are mild. And so where it says level of invasiveness, that's less invasive, and then one can have bladder retraining. Then the first line therapies, if your symptoms are moderate to severe, would be medication, and we'll talk about that. Other therapies that can be done in the office are water vapor therapy, implants into the prostate to open it up, and a microwave therapy in which a catheter, we'll talk about this, in which a catheter is put in. And then the surgical procedures, the gold standard is the TURP. I mean, there's a lot of different options now, and the TURP kind of gets a lot of bad press, but it's the gold standard by which everything else is measured, the outcomes. There's lasers which can basically, you can think, I don't like to say this, but you can think of it like the rotor-rooter job. You're going to be opening up that pipe. So you can use a laser, or you can use the transurethral section of the prostate, or if your prostate is ginormous, then it may require an open prostatectomy. A lot of folks are on saw palmetto and other things like urtica dioica. But these non-conventional therapies are not, have not been, there's been some studies that have suggested it, but in the well-controlled studies, which they've been compared to placebo, there's been no difference. And so at least as far as the American Urological Association goes, no dietary supplement, combination phytotherapeutic agent, or other non-conventional therapy is recommended for the management of lower urinary tract symptoms secondary to BPH. And the other thing is, if you get a medication from a company that makes a pharmaceutical, it's going to be pretty pure, but some of these formulations may have a lot of the active ingredient, and some of them may have very little, because they don't go through the strict regulation and oversight that pharmaceuticals do. Having said that, if you're going to take it, take it. Watchful waiting is for those who have mild symptoms. They don't bother them. And so no medicine, no surgery. And you may want to modify your lifestyle, such as we mentioned earlier, adjusting your diet, taking less fluid in the evening. If you'd have a diuretic, maybe you should take it during the day. And then your exercise patterns. And you'll get a yearly exam with a digital rectal exam. You'll fill out one of these symptom scores and have a PSA check. So there's really no side effects. It's just that your symptoms may worsen or remain unchanged. But if you're getting checked on a regular basis, it'll be picked up early enough. If you don't show up for 10 years, then that's a different story for your recheck. But if you go for a regular check, if your symptoms are worsening, it'll be picked up early, and you don't have to worry about going into renal failure overnight. One of the types of medications, and the ones that's generally used first, is called an alpha blocker, and it works very quickly, and it helps to relax the muscles in the bladder neck and the prostatic urethra, and it allows the urine to flow more freely. And it does work pretty quickly, and folks respond to it in a few days to a couple of weeks. Of course, you don't need anesthesia to take a pill, and it's not a permanent implant. Some folks get dizzy when they take this medication, and in that case, we switch to a lower dose of a different medication, and most folks can tolerate that. But occasionally, there's folks who have a pretty severe symptoms, and they just can't tolerate the medication, so they're actually a good candidate for other treatments, such as the minimally invasive therapies or more invasive therapies. The common drugs are tamsulosin, silodosin, terazosin, doxazosin, and alfuzosin, if that's the generic names. These can cause retrograde ejaculation. If the bladder neck is really relaxed, then when your semen comes out, it's going to take the path of least resistance, and if you have your bladder neck pretty relaxed, it may go upstream. So you'll have a dry climax, basically. That's not harmful. The semen will just come out with your next void, but it does bother some people. Of course, most people in this age group, when I ask them if it bothers them, it doesn't. And I ask them, are you going to have more children? And they usually aren't. There's a pretty high drug discontinuation rate after 12 months of treatment, 62 to 91%. The other type of medication for reducing the size of the prostate are called 5-alpha reductase inhibitors. Testosterone is converted to DHT, or dihydrotestosterone, and by an enzyme, and this medication blocks that conversion of the testosterone, and so it actually shrinks the prostate. Unlike the alpha blockers, the 5-alpha reductase inhibitors may take 6 months to a year to kick in. And so, but when they do, they tend to work. But it takes a while. They also are better for folks with a very large prostate, because if you have a small prostate and you reduce it by 20%, you may not notice any difference, but if you have a very large prostate and you reduce it by 20%, then that could significantly open up the channel for you. Interestingly, the dutasteride was used about 20 years ago. The AUA had a prostate cancer prevention trial in which for several years they administered men dutasteride, which is a 5-alpha reductase inhibitor, and it decreased the risk of development of prostate cancer by about 25%. And interestingly, at one of the meetings they presented some information, and even after these men had stopped it, after 15, 20 years later, after they'd stopped the medication, they still had the protective effect seemed to persist, even though they weren't taking the medication. When you do take these 5-alpha reductase inhibitors, we expect to see your PSA drop to about 50%. So when you get your annual PSA, you expect that to drop. And if it starts going up while you're on the 5-alpha reductase inhibitors, then that's kind of a red flag to screen a little closer for prostate cancer. Some folks complain of a decreased libido, a lower sex drive, and it can cause some gynecomastia, some enlargement of the breast in the male. Water vapor therapy is one of the minimally invasive therapies that are available to treat the prostate. It's done in the office with local anesthetic. It does involve putting a scope into the urethra and then using water vapor, which is injected for a few seconds into different areas of the prostate to eventually, as the prostate heals after getting cooked, the channel will open up. They have data up to 4 years, which it seems to be at least up to 4 years. One sees improvement and persistent improvement. It preserves erectile and urinary functions. You don't get so much retrograde ejaculation, and you can return to activity quickly. General anesthesia is not required. There's no permanent anything put in your urethra, your prostate. And the retreatment rate is about 5%. You may need a catheter for a few days, and for several weeks you're going to have some pain when you urinate, but that clears. And there may be blood in the urine and semen for a couple of weeks, but that also clears. Because the because the prostate's been cooked, some of that fluid that comes out in your ejaculate may be less. The trade name is Resume, and up there in B, you can see that little hook or little coming out, and then in C, through the scope, that is placed into the prostatic tissue through the urethra, and for several seconds it cooks the tissue, and then you move up and down the urethra where the prostate is and heat up the tissue. Some folks have a really big mid portion of the prostate, and this can actually be treated with this therapy too. And so D is the idealized picture of what it looks like after, when it's scarred and shrunk down. Another minimally invasive treatment is called the prostatic urethral lift, or the Urolift is the trade name. It's a non-surgical outpatient procedure, and it uses permanent implants to lift and hold the tissue out of the way so it doesn't block the urethra. It's like a little piece of fishing line, and on either side it has a little hook that comes out when you put it in and squeezes the tissue together. I have a picture after this. It's like a sandwich. It doesn't require general anesthesia, but a lot of times, I do use general anesthesia. It's a permanent implant, and the retreatment rate's about 14% through 5 years. There is going to be some blood in the urine and some pain or discomfort when urinating and urgency, but this goes away after treatment. This doesn't reduce the size of the prostate, so you're squeezing that tissue down. So that's something to keep in mind. So you can see these hooks there. There's that piece of proline suture, and then it's inserted through the prostate through a scope. Then the hook releases, and like an anchor, and then you release the inside, and it squeezes the prostate tissue. And this is a picture before and after. You can see the channels opened up. Actually, that's the left side, your right side. You can see that little silver-looking, gray-looking piece there, about 330. That's the implant hook sitting in there. I found this very useful in folks who are on blood thinners and can't come off, because if they come off, they're going to have a stroke. If they have atrial fibrillation, so they just have to get it for a brief period of time, and they have some bleeding initially, but it works pretty well. The other folks who this is good for are folks who have neurological diseases such as Parkinson's disease, because if we do a TURP or a Roto-Rooter on them, they have a fairly high, up to 30% rate of incontinence after. And so this is one way that the channel can be opened up, and they don't have that same risk because you're actually not removing tissue. Transurethral microwave thermotherapy about 10 or 15 years ago used to be used very commonly. It can be done in the office. A catheter is put into the urethra, and part of the catheter that goes through the prostate has microwave energy in it, and there's water flowing around it, so it doesn't cook the urethra, but it heats up the tissue, kind of similar to the water vapor, but it uses microwave energy, and then after it's taken out, and then the tissue heals and scars, and the opening gets bigger. It's a good procedure for folks who, for whatever reason, can't tolerate an anesthetic, who can't get off their blood thinners and who are really debilitated. And the potential side effects are, as with the other ones, urinary retention and incontinence, infections, slow improvement of symptoms, erectile dysfunction, and decrease in ejaculatory volume. And this used to be used a lot 10 or 15 years ago, but it's not being used that much anymore. But for a certain individual patient who has unique needs, it's a good treatment. It's nice to have it in your armamentarium. There's several types of laser, and I'll talk about the green light laser. It does require general anesthesia. There's no permanent implant, and it's a laser rotor-rooter. It's like a laser TERP, and one uses a side-fire laser to vaporize the tissue. When you're doing it, you're actually seeing bubbles coming off from the tissue because it is being vaporized. The nice thing about the green light laser is it has the same wavelength as hemoglobin, so it doesn't bleed much at all. It kind of cauterizes as you're going along. Usually the folks can go home the same day, and you are reducing the volume of tissue that you're taking out, so the results do persist. There's a minimal blood loss, and once the catheter comes out, and you get an immediate improvement. The retreatment rate is about 4%, and through 3 to 5 years. And just like with whenever you put something in the urethra, whenever you treat the prostatic urethra, it's like you have a big strawberry on it, like you scraped your arm. It's got to heal. And so eventually the raw tissue in the interior of the urethra, where you did the opening up, will heal. And that's when your symptoms get better, when you don't have any more burning or urgency or bleeding. The tendency for retrograde ejaculation is higher with this type of treatment. This is idealized picture, but on A and B you can see the obstructive tissue there coming in from the side, and then on C and D, bladder neck is BN, you can see how opened up it is, and once that heals in, you got a nice channel. And this is similar to transurethral section of the prostate. What you see when you're done is C and D. You see an open channel there. This is from Netter, and it's kind of a scary picture, but it, this is the TURP, but it's the gold standard. And sometimes if I'm doing a green light laser and the tissue just keeps falling in, eventually I will have gotten to the point where I go to the old standard, the TURP, and put that in to finish up. It's a scope, it's fairly large, and it has a little cutting loop through which electricity runs, and you just carve out that obstructing tissue. If you think of your prostate like an orange, the abnormal tissue is the pulp of the orange, and it used to just be, when you're young, it's small, but if you get a lot of obstruction from your prostate, it gets big. And so when you do these types of procedures, you're trimming out the pulp, but leaving the peel. So you don't do anything to the nerves running on the outside of the prostate. And once you trim away the tissue, then you can irrigate out those chips. And one puts a catheter in, and you're in the hospital for maybe 1 or 2 days, and then you can go home after that. The reason I like the prostate has a lot of blood flowing through it, and the reason I like to start with the green light laser is because there's a lot less bleeding. And then if I do have to finish up with something like this, then it doesn't bleed much. General anesthesia is required. Again, this has been used for 60, 80 years. Actually, what are we? We're in 2019, over 100 years this has been used. And the similar side effects, the scope is a little bigger, so you have a chance of scarring in the urethra or at the bladder neck. Rarely, but sometimes it does require transfusion. The incontinence rate is less than 1%, and erectile dysfunction in some studies has been about 10%, although it's kind of hard to explain that because the nerves are running on the outside, and retrograde ejaculation, the dry climaxes, will probably be that's very common because you've opened it up very generously. For those with really large prostates, and this is rarely done anymore, but one can do an open prostatectomy or use the robot, which is being used to do radical prostatectomies for prostate cancer, and it involves opening up, making an incision, opening up the prostate, peel, you can think of it, and then coring it, getting out the pulp, and then sewing it back up. And this is very good for very large prostates. There's a risk of blood transfusion because you are not controlling the bleeding, but getting that out all at once, and there's a large blood flow through the prostate, and of course retrograde ejaculation. So in summary, I hope I've given you some information on what the prostate is and how it works. An enlarged prostate is known as BPH, so it's a non-cancerous enlargement of the prostate, and the symptoms are mainly due to it just squeezing down on the urethra, the bladder having to work harder, and then you get symptoms from the bladder trying to squeeze that urine through. Watchful waiting for mild symptoms, and then first-line therapy, and just about everyone gets medical therapy. I prefer to try folks on medical therapy first because you can always stop a medication, but any sort of surgical therapy is a permanent thing. So I prefer to have people either fail medical therapy or to have side effects from it before I'll proceed to a surgical procedure. So if you're having some of these symptoms or a lot of these symptoms, then consultation with your urologist is the best thing because we do this all day, every day. Today when I was seeing patients, because I have to give this talk, I'm thinking, I'm seeing quite a few patients with BPH, and I guess I don't think about it, but I must have seen 12 of the 25 patients had BPH. So we have a little bit of experience with this. Thank you for your time, and I appreciate your coming out on this stormy night to be here. Thank you.
Okay, so now again, it's time for our question and answer portion. So if you have a question for a doctor, you can raise your hand, and the volunteers in the yellow shirts will come with a microphone so you can ask your question. We'll try and take as many questions as we can. Go ahead, just raise your hand if you have a question.
Thank you, Doctor, for sharing this interesting knowledge. Can you just talk a little bit about the interrelation between Flomax, dark blood in the semen, the retrograde ejaculation, and ED?
What was the first part? I heard blood in the semen. Blood in the semen is a worrisome sign if nothing else has been, you haven't had any surgery or anything, or you haven't had a catheter. If it's just blood in the semen by itself, that could indicate prostate cancer. And so it's important to be evaluated and probably get a biopsy for that. And then you talked about Flomax, was it?
Flomax, you have blood in the semen, erectile dysfunction, and retrograde ejaculation.
Okay. Well, Flomax is tamsulosin. It's the alpha blocker that we talked about that's used to relax the smooth muscle at the bladder, neck, and the prostate, and to allow the urine to flow out better. It's actually one of the first-line medical therapies. And you mentioned Flomax, blood in the semen.
Retrograde ejaculation.
Yeah,
and
that's,
ED.
again, retrograde ejaculation is not uncommon with alpha blocker therapy because it does relax the bladder, neck, and the urethra, and the semen is going to take the path of least resistance, and a lot of time that's up and backwards and up and out. And then erectile dysfunction, well, that's a whole nother topic, but I mean, all those guys at BPH, I asked them if they needed generic Tadalafil, generic Cialis or Viagra. It's, yeah, I mean, there is some risk with these modalities, but it's very low.
Can the Flomax be causing all of this, or is there
No,
an
no,
alternative?
it's not. Flomax is not going to, tamsulosin is not going to cause erectile dysfunction. It may cause retrograde ejaculation. And if you consider the dry climax to be ED, then I guess you could consider it, but it's reversible if you stop the medication.
Thank you.
What tests are used to determine whether you do have cancer?
The screening tests are the PSA and the digital rectal exam of the prostate. There was the preventative task force. It's a long story, but about a decade ago, they recommended no men in the United States be screened for prostate cancer, period. And they got no input from urologists. And the American Urological Association has been lobbying Congress since then, and they have gotten the recommendation changed to a C, to instead of not recommended. It's you think about it, but you may want to consider it. The what's happened in the meantime is a lot of folks have just stopped screening for prostate cancer, which is the most common cancer in men in the United States, and it's resulted in delayed diagnosis in a significant number of folks, and so more people are presenting with advanced disease today because of that halt in the screening. Of course, it's also been good for urologists because before, I think some folks were really gung-ho and everybody was going to get biopsied, everybody was going to get treated with some sort of surgical therapy. But you don't need all prostate cancer is a very varied cancer. You have slow-growing cancer, you have fast-growing cancer, and if you got a high-grade cancer, you probably need to have something done. But just like for BPH, if you have minimal symptoms, if you have a low-grade cancer, if it's not going to advance very rapidly, then you may not need any treatment. And in fact, about half the folks who get diagnosed with prostate cancer today now are on active surveillance, meaning you get rechecked every 6 months or so with a PSA and a digital rectal exam, and at a year later you get a re-biopsy and make sure that there's been no change in the grade of your cancer. But the AUA has now recommended that between the ages of 55 and 70 that you get an annual or every other year digital rectal exam of the prostate and PSA, unless you have a family history of prostate cancer, which is going to increase your risk. or unless you have if you're African American, then you have a higher risk of developing prostate cancer, so you should get screened at a younger age.
I think we have a question down here. This gentleman, she's coming with us.
What is the normal PSA number? What is kind of the range?
Well, it depends on your age, because as we get older, our prostate is enlarging. And so for somebody in their 50s, it's going to be less than 2.8. For somebody in their 60s, it'll be a little higher. And then for somebody who's over 70, which you should probably, it'll be, cutoff will be 6.9. So it depends on your age, what decade you're in. So it used to be everyone said, okay, if it's above 4, then that's a problem. But if it's above 4 and you're 40 or 50 years old, that's a problem. But if it's above 4 and you're 60, that's not a problem, unless it's rising rapidly. If your PSA is 1, then the next year it's 4, then that's a significant jump. It shouldn't go more than about 3/4 of a point a year. It shouldn't change. As long as we're speaking about cancer, you don't have to go directly to a biopsy now. There are MRIs of the prostate are being done and being paid for by insurance more commonly, and that's helpful, although it's not 100%, because even in these centers where the radiologists do a huge number, they still may miss 20% of the clinically significant cancers. There's different tests. There's one called a PCA3. It's also known as a liquid biopsy, meaning after the prostate's checked, massaged, then some of those cells are going to come out in the urethra. And so we collect the first ounce of urine that comes out and send it to a specialized lab, which spins that down and looks for cancer genes, a number of cancer genes in the cells, and then they give you a score. And if they can tell you it's unlikely that this will come back having significant cancer, or if you get a really high score, then that means those cells have cancer genes in them, and it's more likely. So one doesn't have to necessarily go directly to a biopsy itself.
Okay, we have another question on this.
Yes. Does the prostate grow back after you do
Yes.
one of these surgeries, like the TURP?
Yes, it can grow back. I like to think that there's about a 7-year guarantee, but some it lasts for 25, 30 years, the rest of their life. Others, for some reason, it's just boom, it's right back there. I think with some of these less invasive therapies than the scary TURP, one thing with the TURP, you really do get all that tissue out. And with these other therapies, you don't get the tissue out the way you do with the TURP, and that's why it's the gold standard. But yes, it's not uncommon, or I should even say it's common to have to retreat in less than 7 years because of regrowth of the tissue.
We have a question in the back.
Yes, doctor, what is the status of the so-called liquid biopsy to avoid surgical procedure?
Well, it's available, and we, I'll send it off if the person, I'll send it off a lot of times if they've been biopsied and their PSA is still going up. That's where I find the utility. But I wouldn't recommend it just for routine screening before getting a biopsy, especially if one feels a nodule or if your PSA is 10, then that's not really adding to the probability that you have significant cancer there.
But it is available here in Honolulu?
Yeah, yes.
Thank you.
I'll take one more question. Last question over there on the left.
Yeah, I had a question, doctor. Would an internist be a person you could rely on for examination and treatment of a prostate problem instead of a urologist?
It depends on their comfort level. And if they're doing an annual Okole check and if they're getting a PSA, they can certainly start you on the alpha blockers or the 5-alpha reductase inhibitors, and a lot of them do. It just depends on their comfort level. I feel fortunate as a urologist that I just have to focus on the urinary system and the male reproductive system, because I think if I was an internist and I got to look at you from head to toe and worry about your blood pressure, your diabetes, your back pain, your constipation, I think for some primary care doctors, it's easier for them to refer to the urologist, not because they're lazy, but because they just got so many other things to worry about. I mean, it's better for them to refer and keep on top of your heart and your brain and stuff, more important things.
All right, let's give another applause to Dr. Robert Carlisle once again this evening. So we want to also thank Bill Milstein for providing sign language interpretation. Also thanks to the Hawaii Prostate Cancer Coalition, who was in the lobby earlier this evening sharing great information with everyone. Also thank you to our Queens volunteers, Jennifer and Laura. They were in the yellow shirts there, so thank you very much, Jennifer and Laura. So next month, here's what's happening next month. Sometimes serious illness can be seen from afar, such as dementia, and sometimes it strikes you like lightning, such as cancer. Having conversations with your loved ones about care in these types of situations can be stressful, but starting the conversation before serious illness happens can be uncomfortable, but avoiding it can make things even harder down the road. Dr. Michael Tom, a geriatrician, will talk about how to start the conversation about advanced care planning and directives, as well as myths about palliative and hospice care. So again, that's taking place Wednesday, October 30th from 6 to 7 p.m. That's the day before Halloween. It's free, as always, here at the Queens Conference Center. You can register online at queens.org. You can click on classes and events, or you can call the Queens referral line at 691-7117, just like how you registered for this evening's class. So once again, thank you for attending the Queens Medical Center Speaking of Health lecture. Don't forget to get your parking ticket validated in the lobby. Drive home safely.